Hello, my name is Marcin Romańczyk. I'm an endoscopist currently working in HT Medical Center Tychy, which is the Department of Gastroenterology of Academy of Silesia in Poland. I would like to thank on behalf of all co-authors for allowing us to discuss our study's results. The study is titled The Prospective Validation of a Scoring System to Assess Mucosal Cleanliness During Upper Endoscopy, and it was published in January in GIE. Since the very beginning of my training and then practice, I recognized the impact of cleanliness on EGD's outcomes. I was quite surprised that no scale exists for gastroscopy but exists for colonoscopy in terms of preparation of cleanliness during the procedure. So together with friends from Polish Young Endoscopy group, we created a scale that was complementary to the Boston Bowl preparation scale. Our most important goal was to create scale with easy clinical implementation. We call this scale PIS. It is scored from 0 to 3, where 0 means completely obscured, 1 poor cleanliness, 2 good cleanliness, and 3 excellent cleanliness. It consists of assessment of esophagus, stomach, and duodenum. Worst part of each segment should be scored, but after or cleansing, and each patient may accomplish from 0 to 9 points. So, for example, 3 to 3 for esophagus, stomach, and duodenum. And the aim of current study was to validate the scale prospectively. We performed multi-center prospective cross-sectional study done in 5 endoscopic centers. We enrolled 995 symptomatic patients who underwent complete EGD in 2021-2022, and our primary outcome was the detection of clinically significant lesions, namely esophageal, gastric, and duodenal polyps, ulcer, tumor, subepithelial lesions, as well as reflux esophagitis and endoscopic suspicion of Barrett's esophagus. We included patients referred for diagnostic EGD that were adult, and excluded those who were referred for therapeutic EGD for the assessment of known pathology with the history of resections in the upper GI, surgical resections, those who could not undergo biopsy, and pregnant women. The mean age was 56.2 years. The majority were female, and 3 most prevalent indications for EGD were dyspepsia, gastroesophageal reflux disease symptoms, and alarm symptoms. If we split each patient for 3 segments, so esophagus, stomach, and duodenum, then 2,985 segments were assessed. The majority were scored as 3 and 2, and then we had 74 cases of scores 1. So those that were treated by us as poor cleanliness, 56 in stomach, 14 in duodenum, and 4 in the esophagus. None of our patients had a segment scored as 0. Mean score per patient was 8.1, and we, since the very beginning, we treat the cleanliness adequate if all segments were scored at least 2, so 2 and 3. And it was accomplished by 929 patients. We performed multivariate ordered regression analysis to identify risk factors of clinically significant lesion detection, and we found out that the adequate cleanliness, duration of procedure, male gender, and GERD symptoms were the risk factors of detection clinically significant lesions. We also did the same analysis for number of segments with detected polyps, and we found out that again cleanliness, so that adequate cleanliness and duration of EGD, along with sedation, age of more than 60 years, and female gender were risk factors of detection in polyp in each segment. We also found 27 cases of neoplasia, and they were all diagnosed in scores 2 and 3. We also checked factors that impact on cleanliness, and we found out that the age above 60 years, surveillance of gastritis as indication for EGD, and inpatient procedure were the risk factors of inadequate cleanliness. Our study, of course, have several limitations. Firstly, it was not validated within community-based endoscopists. We also based on the retrospective data regarding inter and intra-observer agreement. We didn't reach assumed number of inadequately prepared segments. And our study was not powered for the detection of neoplastic lesions. We also excluded some clinically significant lesions such as esophageal or gastric varices because they are not focal. And finally, we kept scoring from 0 to 3 despite non-significant differences between scores 2 and 3. To conclude, cleanliness assessed with p-scale is related with number of detected clinically significant lesions and number of detected segments with polyps. We have, of course, plans for the future. We want to assess inter-observer agreement based on the videos of EGDs. We want to clarify the difference between scores 2 and 3, and we want to assess impact of inadequate cleanliness on neoplastic lesions detection and missed neoplasia. Finally, we want to assess factors that effects on cleanliness. I hope that you enjoyed our study, and we hope for a broad implementation of our scale to improve EGD quality.